Hello, my name is Dr. Amanda Witt. I am a physical medicine and rehabilitation physician in the neurology department, probably working with some of you or most of you throughout your careers. This is our introductory lecture on spinal cord injury as part of our Neurotrauma Block. So over this block, we'll be talking about the basics. How do you assess a spinal cord injury level, and how do you determine their functional ability from that level? So let's start with a case. Let's say a 16-year-old male presents to the ER following a motor vehicle collision. He was an unrestrained rear seat passenger in a head-on collision. At the scene, he was awake and complained of inability to move or feel his legs. So based on this history, we think that he likely had a hyperflexion injury from the head-on collision based on the impact, and had either a stretch or a bony injury to his spine. There is no significant past medical history, social, family history, no alcohol involved at the time, etc. So on exam, he is alert and oriented, cranial nerves are intact, upper extremities intact with coordination, sensation, and strength. When we check his dermatomes, he has sensation that's intact to light touch and pinprick up to T9, but absent at T10 and below. Actually intact up to T10. He has reflexes in the upper extremities, but none in the lowers, and right now he can't sit up without becoming dizzy. And he obviously cannot stand or walk with no movement in the lower extremities. He seems to not have had a TBI. There's no report that he ever lost consciousness, and now he's very appropriate in the ER. So how do we describe his injury? This becomes very important because when we talk about spinal cord injury and I'm caring for someone, then that means, there we go. These just show you some of the examples of what we see. Most of these are my patients who have had spinal cord injuries, to give you an idea of what we can see from a bony imaging level. Again, we base it on the neurologic function, and I'll tell you some of how these patients have done based on their level. So this one is very dramatic picture. This is a CT of the thoracic spine. This was done when my 14-year-old female patient presented after a car accident. She was sitting in the front seat, she was not restrained, and they had a head-on collision. So you can see the force just popped it, and that's really a jumped, we call it a jump facet, where part of the spine completely dislocates from the other. That was a transection of her spinal cord, which, I mean, it had to be, and then of course when they did surgery for this, because it's obviously unstable, they saw that it was transected as well. She is a complete paraplegic. She has a level that I think is T10, and she went through a rough patch early on, and now she works as a photographer and is engaged and living on her own and doing very, very well. This patient, actually, it's subtle. When you look at a spine x-ray or MRI on the side, what you're looking for is to see if these lines are intact. So right here, if you look at this anterior line, there's a blip here. There's a little irregularity, not too bad though. From that perspective, then we're going on the posterior line behind the vertebra, and then this one catches your eye, right? This was actually a gunshot wound. He was lying in bed and was shot by a roommate. We think that this was gang related. In fact, we know this was gang related. The bullet went, I think, all the way through. Since he has an MRI, we don't see any fragments left. If we had fragments of the bullet, we couldn't do an MRI. But obviously this is displaced. These have bony fragments are coming out from the vertebra. The disc is completely interrupted, and as you were looking at the line back here, that's actually pretty good. He must have had a clean shot through with just some fractures of the spinal process. So the most disruption is here on this level, and that will become important when we talk about whether or not they need surgery. But obviously most of the spinal cord here is damaged, although I don't think it's quite transected. He is a C8 quadriplegic, and he had a complete injury. So his injury and bony abnormality really matched up very well. This little patient was 5, and she had a gunshot wound to the neck as well. However, the gunshot wound did not go through her spinal cord. It went to the side. But what you can see is a subtle increase in signal here. That's from edema that occurred with the in the spinal cord just from the blast effect from the bullet being so close to her. She has actually done extraordinarily well. This happened in April, and now she's ambulatory. She had more, I bet if I could have caught her in the hospital, she would have looked brown sequordish, because she has an asymmetric weakness on the left side that is steadily improving, and it's hard with a 5-year-old to really get them to discern pinprick, cold temperature, vibration. She definitely has loss of light touch on the left compared to the right. But it's a little hard to see that splinting at this point. But she went from having no movement in the left arm, and now she is 4- to 5 out of 5, which means she can push you against resistance with all of her muscle groups. In her leg, she has some hip girdle weakness, but is ambulatory and running. If you get her to push a little further, like have her skip, she really can't skip on that left leg. She doesn't have the coordination and push off on that side. And if you have her stand on her left leg, just single leg stance, she'll drop her right hip. So she's got a Trendelenburg from gluteus medius weakness. That gluteus medius can't stabilize the pelvis, so the right leg drops. But overall, she's doing very, very well, about 5 months post-injury, and she will continue to do very well. She's also in a different home environment now. These were ones I got off the web just because I wanted you to see this. I couldn't remember which of my patients had that signal. That's a transected spinal cord. With that bright, bright, bright signal transverse in the spinal cord is a transection. I don't know the cause or anything of this one, but it's such a hallmark sign I wanted you to be aware of. And then again, this shows another picture of what would have to be a transected spinal cord with a complete disruption of the spine. She did not have to have any surgery because all of these are very, very stable. All these lines are gorgeous. He did not have to have surgery. What was done was done. She did. So when you have 2 of these lines disrupted, 2 or more, 1, 2, 3 being the lines, then they do surgery with neurosurgery to stabilize it and prevent further injury. And so what would be the difference between, let's see, myself and Dr. Washington approaching a spinal cord injury? Up front and foremost, neurosurgery is critical, and the first person who should assess to see if the spine is stable, determine if they need surgery to stabilize the spine, and if they need surgery, should they go in from the front or the back? Which one is better? If there's a gunshot wound and there's fragments, usually that is a wasted cause to go in and just dig out fragments. You're going to cause more damage. But if that spine is unstable, obviously you have to fuse it. They're also critical in the acute ICU management of these injuries and help with that early prevention of secondary tissue injury. And that would be making sure that their oxygenation and their respiratory status is stable, that their blood pressure is stable, because we want that area to get good blood flow and oxygen. We do not want a secondary anoxic injury to those tissues. Sometimes they'll also be treated with steroids to help with the inflammation issue and help prevent secondary necrosis. If there's other injuries to the patient, then they can help coordinate the team and make sure the right people are involved. Do they also have a fracture somewhere? Do they have a comorbid brain injury, which is not uncommon, especially in higher cervical spine injuries related to like a car accident as opposed to a gunshot wound. And they help with the initial team coordination. Physical medicine and rehab is what I do. It's also called physiatry or PM&R, and what we do is we focus on the function. So we get involved pretty early on, ideally in the ICU stage, but most certainly by the time they're on the floor, because many of the complications that can occur in spinal cord injury can be prevented or at least avoided completely if we can get involved and make sure we get the list done. Because spinal cord injuries tend to be underestimated as far as the depth and the breadth of what they affect in a person. It's not just not being able to walk. So we go in, we assess, we want to know the neurologic level, assess if it's complete or incomplete, and now you know how to do that. We want to know if the autonomic system will be involved. And that has to do with where this sympathetic chain lies near the spine, and so if the patient has a T6 level of injury or above, they are likely to have dysautonomia. And our patient had already complained of that. If he sat up, he got dizzy. So that orthostasis, or that drop in blood pressure with being upright, is an early sign of dysautonomia, where that autonomic nervous system is going to be impacted too. That also can cause heart arrhythmias. It can cause sweating and temperature dysregulation. And we'll talk a little bit more acutely. Those are our primary focus. A little bit later, we'll talk about how that can affect things chronically. Bladder management is important. The spinal cord injury, the spinal cord itself connects the brain to everything else, and that includes your gut and your heart and your lungs and those little tissues and the little tissues in the gut that do peristalsis, and the blood vessel regulation in the small vessels. All of that gets managed by the nervous system. The bladder operates based on a micturition center in the pons that controls how the nerves function. When you are going about your business and you want to just hold your urine and not have to stop, then your holding detrusor muscle relaxes and the sphincter, the internal sphincter, constricts. If you decide to avoid your bladder, or you feel that it's overstretched and the nerve process switches over, relaxes the sphincter and contracts the detrusor. With a spinal cord injury, it goes cattywampus. You no longer have any connection from the nerves going to your bladder to the pons micturition center. And so what happens is the detrusor muscle, kind of with every other muscle that's affected in the beginning, is real floppy, and then will get spastic. And then the sphincter stays tight. So then you have this full bladder that can't empty, and you can't feel if it's full or not. So we have to work on making sure we empty the bladder safely. If we do not empty the bladder and we're not paying attention to the bladder that's holding urine, eventually it'll start leaking. And if it's leaking out, it's also refluxing up into the kidneys. And before we really had good management strategies of the bladder and spinal cord injury, let's say in the 1970s, a lot of patients would pass away from renal failure. So all these little things add up to something that can be very critical. Bowel management, they can't feel when they have to go to the bathroom. Even incompletes are going to have trouble going to the bathroom even if they have sensation, because they're not moving as well. They're on medications all of a sudden. The trauma itself can cause slowed gut motility, so bowel management is important. These patients will have an increased risk of deep vein thrombosis. They're hypercoagulable after trauma, and with immobility, and with ongoing inflammation in the body. And so for the first 2 months, we have to seriously consider what we're going to do for DVT prophylaxis. And if it's not contraindicated, they will all be on chemical anticoagulation with Lovenox or heparin. Lovenox is a little easier to give them. Wound prevention, so they're not going to be able to film their skin, not just on their bottom, but on their legs and around their ankles and on their feet and in their toes. And all those things can have compression depending on if they're laying in bed all the time or up in their chair. And also spinal shock, which we'll talk about, is important to know if they're still in kind of all the muscles floppy, no reflexes stage, where the body just kind of shuts down all those reflexes, or are those reflexes starting to come back? So we'll talk about that a little bit. So let's review a little bit of anatomy. So when we look at spinal cord and we want to get that neurologic level and not just the bony level, we look at two things. We look at the dermatomes, and this is a little review of the dermatomes. I wanted to show you this picture first because you can really see why this exam style works. There's a specific exam called the ASIA, A-S-I-A, and we'll get to that on the next slide, American Spinal Cord Injury Assessment. This is standardized. It was made for research so that we definitively know we can compare apples to apples, oranges to oranges in spinal cord injury research. But it's also very helpful clinically to know how these patients, what they can expect and what kind of activities you're going to be able to help them with, what kind of equipment they're going to need, etc. So we check, this will be a little more obvious on the next slide. So if we're going to check C5 and C6, C7, we're not going to stick them everywhere on that dermatome. We find pinpoint places on the skin that represent the dermatome, and we can move through very quickly. The other benefit to this is if you know this strategy, it's also easier to check for normal things like radiculopathies and find that spine level that is affected. So for C5, we check the outside of the shoulder, C6 the thumb, C7 the middle finger at the tip, C8 the pinky at the tip, T1, this one's a little skewed. They usually do T1 at the inner elbow, T2 at the top. And then you start on the trunk. And the trunk is a little more circumferential, where you have T4 on the nipple line, so you can kind of grade that. T6 at the xiphoid, T10 on the belly button. T12 is right at that inguinal ligament. And then there you go with the lower extremities. And so we also do pinpoint places to get the dermatomes in the leg, and of course we also check the rectal area. The muscles have very similar things. We have myotomes, and so we do manual muscle testing to these specific muscles looking for their myotome relation. So elbow flexors, so biceps is C5, wrist extension C6, triceps C7, finger flexors C8, and finger abductors T1. Then we have a period of time where only sensation is going to give us our level, because we're not going to check muscles in the thorax. And then we move on to a lower extremity. Look back through these. I think they're very helpful. They are also very helpful just in general practice, because whatever you do, you're going to be seeing people with back and neck pain. Here is the sheet for the ASIA exam. You can see on the dermatome model on the right how they have those pinpoint marks for where you check for the different levels. And then the fingers are highlighted and zoomed in the legs. And so, you know, kind of practice on yourself, practice on each other, kind of figure out these dermatome points. They will be handy for a little quick and dirty check. I use it in neurology not infrequently, especially if I have a patient with a neuropathy that I think may have also a pinched nerve in their back. I can pick up their pattern. Is it a proximal distal pattern, or is it a radicular pattern? This is a very helpful little tool. And then we go through. The level of injury is where you have intact motor and sensory. It's the last level you have everything intact. There's a little bit of variability you can do on the motors, just because we know some recovery will take place early on. But in general, we want everything to be the same. If you have a little kid like my 5-year-old that had left-sided weakness instead of right, then you might say left ASIA C, which we'll talk about ASIA, C6 spinal cord injury, because she was C6 on the left. So you can say C7 on the left, C5 on the right. Cervical injuries can be asymmetric. Or you could just call them C5. You could just call them the last level, everything's intact. So the reason I went through that is to show you how these patients will function and to emphasize how independent and they can be with just a little bit of function. So if you have a paraplegia where you have full arm strength, you're independent. So any thoracic or lumbar injury can be completely independent. Now they may have to use a catheter to drain their bladder a few times a day. They may have to use certain tricks to get their bowels to work when they want them to. They may have to use hand controls when they drive, but they don't need another person to assist them to live their daily life. They can find a way to drive and have an apartment and have a family, etc. Have a job. If in the cervical spine, it dices out a little bit. C6 is actually the highest level that can be considered to be independent. Now, you have to have a very motivated C6, because what this means is that you have elbow flexion and wrist extension, but you don't have any triceps. And it's really hard to transfer and move around without your triceps muscle. I've seen people do it. A lot of times this means that they may have to have a suprapubic catheter, where they've had surgery to be able to catheterize their bladder through the belly, or they have different things to help them with their bowel program, which usually means timed with suppositories, but they can do it. So C6 can be pretty independent. C7, so now you've got your triceps. They can be fully independent. One of our recreation therapists at the rehab hospital where I trained was a C7, and she drove her van in. She was the recreation therapist for the patient. She played rugby. She played wheelchair rugby. Her triceps were huge. And she taught patients how to live and to have fun with a spinal cord injury. What they enjoyed before, try to find a way to modify it, and that includes water skiing, sports, bowling, fishing, hunting, all those things that you might need to adapt, but you can still do with a spinal cord injury. C8T1, of course, is independent. You still have hand weakness, so it doesn't make it easy, but it still can be possible, and they can drive as well. So those are more complete patterns. Incomplete syndromes are categorized like this. So we know that incomplete means they have rectal sensation. So that's great. But I told you that just because they're incomplete doesn't mean they have the same chance to walk. So they can show up with incomplete and just have sensation below the level of injury. They can have sensation and motor, or they can be completely normal and have had, at least with strength and sensation, and have had a spinal cord injury. So ASIA B means you have sensation only. Patients can graduate from one stage to the next. So I had a patient who was 13, had a gunshot wound. He was just random. We still don't know exactly what happened. He was out on his grandparents' land. He started out ASIA B. He could feel bladder and bowel. He always could control them. He had full sensation below his level, but no movement while he was in the hospital. It took probably 12 to 14 months after his injury for him to be able to walk. And he ambulates all the time now. He has spasticity in his back and his legs that we have to treat. He has nerve pain in his back and legs. And he has some weakness around his hip girdle and lower back that we have to compensate for. But he's played wheelchair basketball. He's gotten a scholarship for wheelchair basketball because he's not functional enough to play basketball with patients who are fully ambulatory. But he went from an ASIA B to an ASIA D. Like I said, probably within at least 18 months of his injury. So he was able to graduate and gain motor over time. Not everybody does that. Sometimes you stay in your level, but there is upward mobility, so to speak. So ASIA C and D are similar in that they have sensation. They also have muscle movement below the level of the injury, at least 3 levels below or more. But it depends on how much of those muscles have anti-gravity strength or not. If you can lift it against gravity or even provide resistance to more than half of your muscles below the level, then you're a D. If it's less than half, you're a C. So there's just a little bit of variation there. ASIA E does not mean us. It does not mean someone without a spinal cord injury. These patients have had a spinal cord injury, but graduate to the point where they have full sensory sensation and strength. Now, they may have neuropathic pain, although that's kind of fudgy. You should have normal strength and sensation and no pain, but they probably could have some hyperesthesia. They have increased reflexes. They probably have some increased spasticity, but they're doing really well. And this, let's see. This is just to kind of remind us why you might have an incomplete syndrome. So common syndromes would include central cord, and that's with this guy, right? This is with the dorsal columns primarily. This is a classic example of maybe an older patient who falls, they have hyperextension injury, they've already had some arthritis in their neck, that spinal cord was a little tight coming through part of the spine, they hyperflex or hyperextend, and now they've got a spinal cord injury. Usually they'll have more of an issue in their upper extremities because that's at the level of the injury, and their legs don't have as much effect. But they'll have light touch and vibration changes, maybe cold temperature and pinprick are a little better, but that's a very, very common incomplete spinal cord injury, especially as our population ages. Another one would be anterior spinal artery syndrome, and that can happen in a big heart surgery or significant surgery that can cause a drop in blood pressure. The anterior spinal artery covers the first third of the spinal cord. The back 2/3 are covered by the vertebral arteries. So when you lose that anterior artery, it can be a clot thrown for maybe an autoimmune vascular issue, or loss of sensation with low blood pressure. I actually had one gentleman shoot himself in the stomach, and he wound up with an anterior artery syndrome, partially because of the force. I think the bullet went back fairly close to that, and secondly because of the blood loss. So you would expect them to have weakness in both legs because you are affecting one of the corticospinal tracts. You're also dealing with the spinothalamic tract there, and so they'll have weakness with cold and pain, like temperature pain, tracts affected, with intact proprioception, vibration, light touch. So it's almost the opposite of the central cord. Brown's cord is, of course, the one we love to talk about and the one that we rarely see, where you knock out half. And that could be like my kiddo that had a left-sided gunshot wound. She had a left-sided wound. Corticospinal tracts are already divided. She had left-sided weakness with some patchy numbness, and she's recovered pretty well. Some kind of trauma would have to be a Brown's cord, either a gunshot wound or a stab. It's not physiologic typically.